So Medicare Part D is optional. It varies depending on where you live and which plan you get, but you know, it's between something like $80 and a couple $100 a month. And also, this is the first instance, I think, where in Medicare, where it is, where there is a penalty for high income people. So, for example, if you get Medicare Part D and you have a high income, you pay an extra $80 a month for the Part D, which makes sense because it's an incredible bargain. And about 2/3 of Medicare recipients currently have it. And you can get information on the name of the drug, the ID for the prescriber, dose, number of days supply, and every time the script is filled. So ideally then you can say whether the person's taking or not, because if they're getting, you know, 90 days supply 3 or 4 times a year, then you have to assume they're taking it. And what we have is when it's filled, not when it's written, which is good. Limitation is that Part D data are kind of off on their own. They are tied to the patient, but they're not tied to the provider, so that the ID of the provider in the Part D data is not the same as the ID of the provider in the Part A and B data. So for example, if you wanted to say, well, is this person who wrote this patient this prescription, is he their PCP, or is he their oncologist, or is she their, you know, the only orthopedic surgeon that they saw? You can't do that because you can't link from the ID in the Part D to the ID in the Part A and B, unless you get special permission, which we're going to try to get.
Is it the same between Medicare and SEER Medicare, or are you talking about the 100% Medicare? And is a provider ID, can you send it back and have it linked?
Yeah,
like
you can if you ask real nicely.
So you can't link it across the claims, but you could link it to specialty through AMA.
Yeah. And then on the Part D claim, they don't give a reason for it. And so if you want to know why someone got a drug, you have to go back to the visit that maybe they had a visit on the day that they filled the prescription, or maybe they had a visit in a couple weeks before, and you can look at those diagnoses and you can infer, but you really can't really say what the, you know, for some are obviously, or some are obvious, but some are not. So as I talked about, you can do various things. You can do the policy stuff and the impact of donut holes and all that stuff. You can do the stuff that we do all the time with everything, you know, with surgery, with chemo, with everything. You look at time trends, you look at geographic variation, you look at predictors of use. You can do toxicity. What I think is kind of neat, which we've just gotten into in the last 6 months, is drug interactions, where you can measure the impact of the drug interaction. In other words, the outcome of the drug interaction. What is the risk? And then you can also look at the prevalence and stuff like that. So, and physician level stuff. So that's really cool. And some people do comparative effectiveness. There have been a few studies looking at comparative effectiveness of this drug versus that drug using Medicare Part D, but we haven't. So what you can do with Part D, we have been doing for probably 13 or 14 years, just using the Medicare Part A and B for parenterally given drugs. In other words, drugs that you give IV are reimbursed under Part A, and so we always were able to identify them. And so we could do things like look at toxicity or look at time trends and stuff like that. So some of this stuff was sort of, we already knew the way to address the questions. I think the first one we ever did was Shanlin Du back in about 2000, did one on hospitalizations for chemotherapy toxicity in the month after receiving chemotherapy when he was a postdoc down here. And so in terms of, this is actually an old slide that is more looking at it from the perspective of parenteral drugs, but it's also true for Part D. The advantages are you have everyone. You have well, you don't have the people in HMOs, but basically you've got a huge sample. It's a real world sample. It's people with all sorts of different comorbidities. It's 95-year-olds and 65-year-olds and all that. And if you're looking for a rare toxicity or a late toxicity, it's definitely the way to go. If it's a rare toxicity, you've got a huge denominator. And so you can see rare toxicities. And late toxicities, you can follow these people out for maybe 10 years and see their late toxicities. The disadvantages, like with anything in observational work, there still is a certain amount of potential for selection bias in some of the things we would be asking, certainly with the comparative effectiveness part. There can be an underreporting of either the predictors of why someone gets a drug and also the outcomes. And then when you're looking at drug toxicity using observational, you really have to worry about contamination by publicity. That, you know, we were going to do a study like this, and I think we started and I forgot what happened, but where there was a potential toxicity of a drug, and then it hit the New York Times, and we were going to look at a Medicare, you know, reported toxicity before and after, just to show the effects, because some things are all publicity. I mean, the silicone breast thing, which shut down, you know, probably the biggest chemical company in the world, turned out not to be the case, as you know, as far as the IOM was concerned. So contamination by publicity can have a huge effect on assessing toxicity. So we did a bunch with Lupron, with GnRH agonists, and this was one that Vahak and Shahinian did in the New England Journal about 10 years ago. And the nice thing when you're the first person to do these things is you can keep it real simple. You don't have to be real complex. This was just a dose response where we followed free from a fracture and, you know, looked at people after diagnosis of prostate. These are, I think, unadjusted, but the adjusted was essentially the same. And, you know, showing a nice dose response that people who didn't get GnRH agonists, but then with increasing doses, they had increasing risk of fracture going forward. And a similar type of thing, this was the first population-based study of bisphosphonates with the jaw problem, the osteonecrosis of the jaw, because back in the 90s and early 2000s, everyone knew that IV bisphosphonates were great for breast cancer. What we didn't know was that, you know, how much you had to give, and so there were women who were getting, you know, monthly IV bisphosphonate injections, and then it turned out that there was a fairly, actually this is not a small risk. I mean, this is like now this is over a 6-year period, and many of these women weren't living 6 years because they had metastatic breast cancer, but still you can see it's a rather substantial risk associated with IV bisphosphonate use of having osteonecrosis of the jaw. Or you can just do time trends. This is a study that we did last year, I think, on just looking at use of androgen prescriptions by men. And this is men over 40. Okay, this is not, we're using United Health data. So 3% of all men. There are not that many men in this room, but so I can't say one of you was on androgens, but 3% of men in this country got an androgen prescribed in 2011. So that's all we had to say. You know, we didn't do anything fancy. When we looked at the sort of a cumulative, how long they were on it. So all of these people got at least one script for androgens in 2011. And then it turns out that almost 20% just got 1 month's supply and stopped, and, you know, 30% either got 1 or 2 months, and, you know, about half got 4 months or less. And then if they have more than 6 months supply, we sort of tend to think of that for a drug like Antigen as probably they're taking it full time. So I'm going to spend most time on this. I'll get back to, in the end, with opioids, giving opioids studies that Yongfang Kuo and Michaela Raji are doing right now, that Jay Zhao is doing the analyses for. But this is a couple studies we've done recently, and I'm pretty sure we're going to do more on on drug interactions. And it turned out nicer than I thought it was going to be. So sulfonylureas are, for many years, was the #1 oral drug that you gave, the pill that you gave for people who had adult onset diabetes mellitus. So most people with diabetes get it as adults. They're chubby. Often they get diabetes. They get put on a pill. It is adult onset diabetes is usually not treated with insulin. And this was the #1 drug. I think maybe metformin may be the #1 drug now, but these drugs are still very, very frequently used. They're very frequently used in the U.S. And it turns out that a number of antibiotics interact with sulfonylureas. And I'll show you a slide. And we've kind of known that. So like when you're writing an antibiotic in the clinic and someone's on sulfonylurea, something will pop up and say, potential drug interaction. Now the problem is that there's probably not a drug that you can write on your patient with an EMR where something won't pop up saying potential drug interaction. So what do? We ignore it. We just, And the thing is that some of these are important and some aren't. And it's been just remarkable how little we know about that. It's just remarkable how little work has been done in terms of educating physicians about, you really have to pay attention to this. I mean, the only one that I know for sure in my head is warfarin, Coumadin. You better watch out when you give antibiotics to Coumadin because, they're going to bleed like stink if you don't, But everywhere else, people are always going around and saying, oh yeah, drug interactions are important. But then when you look at the list, it goes on, so every potential drug interacting with everything else, and you don't know which ones are real or not. And there's not that much data on it, because it's, you're not going to get those data in clinical trials, because you're not going to allow those people to be into clinical trials, the ones who are on these other drugs. So, but we know theoretically that antibiotics interfere with sulfonylureas by P450. The sort of the detoxifying system, and by other mechanisms. And there have been a number of studies buried in the pharmacological literature about chemical interactions. But very few studies on the actual prevalence and risk of hypoglycemia after an older person is on an antibiotic. So this is like a classic thing you can do with Part D data. We took these are data from Texas. I'll show you some data from the US, but these are data from Texas that we started with. So we just took everyone who got a script for glipizide or glyburide, which are the two big sulfonylureas. 140,000 people, a lot of people in Texas who got at least one script. And then we just looked, and so let's say you got a script on March 1st, then you got a 30-day supply. Then we went out for those 30 days, and if they got a script for any antibiotic during that 30 days, we said that was an overlap. Okay, so when we flagged those, they were overlapping with an antibiotic. And we looked at the 16 most commonly used antibiotics in this population. So mostly, probably 85% of the time, I can't remember, it was at least a 3-day overlap. I mean, because typically people who are on a sulfonylurea are going to be on it all the time. Those are chronic drugs, so they're not going to go off and on. So typically when we saw an overlap, it was for an extended period of time. And then we looked at the outcomes of ER visit or hospitalization for hypoglycemia within a couple of weeks after that script was filled for antibiotic. And we also checked Medicare costs for those visits. And then we started by looking, I think there were 6 or 7 that we said, we think these drugs interact, and then we took another 6 or 7, and we said, you know, there's no theoretical reason why these drugs should interact, you know, given their chemistry and how they're metabolized, and there's been no reports of interaction. So we use them as the controls, because you have to use another antibiotic as a control, because when you get an antibiotic, why do you get that? Because you're sick, right? And if you're sick, you're going to stop eating, and if you stop eating, you may get hypoglycemia. So you can't, you know, you have to control for sort of severity of disease. These are the interacting antibiotics, and I didn't, I didn't know about any of them except for Bactrim, the last one, sulfamethoxazole trimethoprim. And they work in weird and wonderful ways. I mean, ciprofloxacin stimulates, just like you know, sulfonylurea stimulates insulin release. And then some of these others work, you know, through inhibiting stuff in the intestine and thereby interfering with metabolism of the drug. And then the ones that we always think about are these P450 metabolism. You know, there's a whole path in the liver of drug metabolism that is important for many drugs that are where the prime way you get rid of them is to metabolize them, to detoxify them as opposed to excrete them in the kidney. And a lot of them work that way. So, and then here were the ones where there was just absolutely no evidence. And, you know, and there wasn't too much difference between these drugs in terms of how big they were or what kind of serious illnesses they might be. And so then what we did is we just compared these, the outcomes for these, versus the first thing we did is we just took the 3 most popular drugs and did different models. So here we're looking at odds of hospitalization or emergency room visits for hypoglycemia within a couple weeks after getting the antibiotic for each of these antibiotics, and then we ran a different model. Each one of these is a different model, and then each one of these is a different model, comparing it to Zithromax or amoxicillin or cephalexin, which were the 3 most commonly prescribed antibiotics not on this list. And you see an enormous number of numbers there, but what you can basically see is that for some of the drugs, it looks like there's a significantly greater risk against each one of these. And then for some of the drugs, it isn't really totally clear that there is. And so then what we did is, and this was just for glyburide, and we did the same thing for glipizide, and the data were very, very similar. So here's where, as the next step, we combined glipizide and glyburide. And rather than having separate controls, we combined all the non-interacting antimicrobials as the control. So this was any patient who got any of those non-interacting antimicrobials as opposed to a particular one. And then we looked at the risk, once again, of these 7 drugs of hospitalization or ER visit. And 5 of them had significantly higher hospitalizations or ER visits, going from like 62% higher to 3.96 is the highest with clarithromycin, Bactrim or trimethoprim, sulfamethoxazole, the last one down here, 2.5-fold. And then you can see the number needed to harm. In other words, the number of people who had to be prescribed any of these drugs who were on glipizide or glyburide to cause 1 ER visit or hospitalization, 1 excess ER visit or hospitalization for hypoglycemia. And then some of the other associations are, as you might expect, the risk goes up a little with age. There weren't a lot of striking interactions between some of these other things and a risk and the drug and exposure to the drug. There wasn't an interaction of that on the outcome. Having prior hypoglycemia was a major predictor. And we controlled for indication for the antibiotic prescription. Now this was indication for the antibiotic prescription was inferential. We took the 2 weeks before they got the antibiotic and we looked for any sort of infection diagnosis. So it's less than perfect. And I think wasn't it like 30% we didn't find anything? I mean, it was like no information on a chunk, or 20% or something like that. It was so we had that as a separate category. Now, the thing is that these drugs are the use of these drugs in people on glyburide and glipizide is really quite common. So we just looked at, this is another way of doing it, but just find everyone who were on glyburide and glipizide and finding what percent of them in 2007 or 2009 had a prescription for this that overlapped the glipizide or glyburide. So you're not talking about a small number. I mean, it's like, 10% for most of these drugs, and if you look at any, it's like, 28%. 28% of people who are on glipizide or glyburide received one interacting antibiotic during that year. And you have to assume, I should mention, that there are non-interacting drugs that could be given. In other words, when you look at these things, it is rare that a clinician would say, oh yeah, but this drug is, this drug doesn't have any comparable type drugs that you could give from the non-interacting list. So this is not necessary, the use of these interacting drugs. And we looked at several things. I mean, we looked at deaths, and there was a significantly higher death rate. Death rate was small. It was like 9 deaths in 50,000, so that's like 1 per 5,000, I guess, episodes. But it was significantly higher than after getting a non-interacting antibiotic. The costs were higher, and when we totaled up all the costs and we divided it by all the times a person on glipizide or glyburide got a script for an interacting antibiotic, it came up to about $30. So every time you write a script for an interacting antibiotic, because one reason I give Bactrim is it's cheap. And it's a wonderful drug. It's got 2 drugs in it, and one sort of sneaks up and does this, and you gotta go bam, and it's really hard to get resistant to it. And it's cheap, and it's been around for 30 years, and so, we know a lot about it. But it isn't cheap when you have to add $30 to every script from the toxicity you've caused by prescribing it. So, it's not as economic as it looks. And then when we did some things going backwards, we calculated that about 13% of all the hospitalizations and ER visits for hypoglycemia for people who were on sulfonylureas were preceded by one of these antibiotics. So it's not a small, it's responsible for a big chunk of a bad outcome. So basically a high proportion are getting it. It's associated with bad outcomes, and inexpensive antibiotics may not be inexpensive when they're given to people on sulfonylureas because they cause toxicity. So we can do the same thing with national data. So this is national 5% data. Here all we're looking at is prevalence of people who were on glipizide or glyburide who just got Bactrim. Not who got any of these drugs, but who just got sulfamethoxazole trimethoprim, okay? In Texas, that was about 10% of the people. When you look nationally, it's a huge variation, I mean, these things down here is greater than 25%. So like in some of the areas of the country, 25% of the people who are on a sulfonylurea get Bactrim at some time during the year. Oh, this is 2 years, isn't it? Yeah, this is 2 years. That's why the percentages are somewhat higher. But that's kind of scary. And Geographic variation is sort of what you like to see because then you can do clever studies. The only thing we did on this report, this was something that came out a couple months ago that Dr. Tan did, was we correlated the HRR, the supply of primary care docs and the HRR with your risk of getting this bad drug, and showing that the fewer primary care physicians there were, the higher your chance of having a drug that was not a good drug for you. So the next thing we always do is we go to small print. It's like, okay, we've done enough big print, let's go to small print. We look at the same issue at the level of the primary care physician, because we're asking the question, are some primary care physicians better than others in terms of avoiding giving bad drugs to people? Because we're calling these drugs bad now. We've already shown that they cause significant interaction, increased death, increased hospitalization, increased costs. No reason to think they have an increased efficacy because they're similar to the antibiotics that don't interact. And so now we're asking, do physicians vary in their use of bad interacting drugs? And so we start with the 2.8 million Medicare beneficiaries, and then we go down to the D, people enrolled in D. You can do this, you can come at it a lot of different ways, but we just went directly to enrollment in D, and then we found out the ones that were getting sulfonylurea in some year, 2007, and then we restricted it to Texas prescribers, and then we restricted it to beneficiaries who got their drug from a prescriber who had written sulfonylureas for at least 10 different people, because then we figured that was a sufficient denominator to begin to look at. Really, you need more than 10, but we started with 10 to look at, because then we're taking those 10 people and we're saying what percent of them got one of those interacting antibiotics during the year. So there was very little variation. So this is at the level of the PCP. This is how we present our provider level stuff all the time. We look at a behavior on a provider. In this case, the behavior is what percent of patients that are on a sulfonylurea, that are cared for by that provider, what percent of those patients get an interacting antibiotic during the year? Okay, so that's the outcome, so that's here. And then we graph the lowest one, the next lowest, and the next lowest one on up, and we have around 6,000 what are called generalist physicians, general internal medicine, geriatrics, family medicine in Texas. And this is the cumulative distribution. And this is from a multi-level model that sticks in all that stuff I showed you initially when I was showing you the models, indication for the disease and whether they'd had, a bunch of other stuff. So it throws in a bunch of, it throws in a bunch of patient characteristics. And then you ask the model what physicians are significantly higher than the mean rate and what physicians are significantly lower. And for some things, when we were looking at Lupron use, we were getting a huge chunk that were significantly higher, a huge chunk significantly lower. What are some of the other ones we were doing where we got a big difference? Taylor, anytime she looks at surgeons, huge variation, at the level of the surgeon in various activities. Here we found very little variation. It's like once again, a high percentage of their patients were getting an interacting antibiotic during the year, and it was hard to identify, a bunch of docs who were significantly lower. I'll show you some more slides later where we do show variation.
Was it the same physician that had to prescribe both, or not necessarily?
Not necessarily.
But it was a physician that wrote the antibiotic when the patient was already on the sulfonylurea.
We did it a bunch of ways. We did it where the same physician had to prescribe both, and then we did it by the person, I think we did it by the person who wrote the sulfonylurea, but I can't remember. Yes?
Were all 10 or more of the people, of the physician's patients, on an antibiotic of some sort during the year?
No. They were just on the sulfonylurea.
Okay.
So one of the underlying forces is that, how many needed to be, or how, so driving any sort of variation, there wasn't any, but if there had been, driving the variation could be, does this doc just give antibiotics to everyone? And and some of the time that happens to be interacting. There's a lot of different things like that. And there are CMS published data on variation in antibiotic prescribing in the U.S. geographically, and there is not huge variation, but there's measurable variation. South, typically with anything like that, South has more antibiotics. I don't know why. But anyway, thing here, ICC 0.02. 2% of the variation is on whether you get an interacting antibiotic is explained by what PCP you go to, as opposed to some of the more recent stuff we've done where 25% of the variation is explained by what PCP you go to. And so we haven't done everything here, but this was, since there didn't seem to be much variation, the question is, well, do they know about it? And when I say, do they know about it, really I'm saying, do we know about it? Do we, being a Texas, primary care physician, do we know about this phenomenon? Because typically, when you have a bad thing in medicine, you do see variation. That's when you really see variation. When you have over-treatment or something like that, that's when you see the variation, because some of the docs know about it. They get it, and they don't do it. And some of the docs don't know about it, and they do it, okay? And that's when you get variation. But we got very little variation, even though we're talking about something which is responsible for a fair amount of toxicity. So it's like, do they know about it? And a couple of ways of addressing it. I'll just show you one. But this is, okay, well, let's look at their rate of the same PCPs and their rate of prescribing an overlapping antibiotic in someone who's on metformin, which is another pill that you take for diabetes, very good medicine, and it doesn't interact, okay? Versus, what's their rate of overlap at the rate of the PCP for sulfonylureas? And so the thinking was that if there were ones who got it, and this is trying indirectly to control for antibiotic prescribing and all that, if there are people who got it, you would expect that there would be people who had, some sort of rate of prescribing of interacting antibiotics with metformin, because they don't interact with metformin, okay? But whatever the rate was, the rate would be lower when you looked at their rate for prescribing antibiotics with people on sulfonylureas. So you would expect a change in slope. You would expect maybe that there would be people who would be lower on this scale and higher on this scale, stuff like that. And you don't see anything. You don't see anything. If anything, the slope is a little turned in the wrong direction. It's close to 1, but the slope is the wrong direction from 1 to support the hypothesis that physicians are making some sort of selection in terms of antibiotics they choose, whether that patient happens to be on metformin versus sulfonylureas. So I think, what this means is we don't know about this. There was an article in JAMA 8 or 9 or 10 years ago on interaction of Bactrim with sulfonylureas, showing kind of the same data we did. So it's not like it hadn't been out there. On the other hand, it's not on the PDR for most of those antibiotics, and it's not in a lot of websites. So I think it's like when I started out saying I wanted to frame this, I don't know. We haven't tried to write anything about that. I mean, other than the papers, we haven't tried to do anything with this. So let me finish up with something that Yongfang Kuo and Michaela Raji actually did put a grant into. And not only did they put a grant into it, but they put a grant into the National Institute of Drug Abuse. So, wow. I mean, yeah, I mean, it's not complementary medicine, but it's getting there. So I'm kind of optimistic about this grant. It probably gets reviewed in November or so, right? October. But I'm kind of optimistic. But here's some of the preliminary data. They got a cohort. These are also people from Texas. What they did very early on is eliminate anyone with a cancer history. And then they're just looking at people who got an opioid prescription. That includes Vicodin and Tylenol number 3 and the serious stuff. Now the reason this is important is that I've been around a long time. And when I started out, there was no doubt in anyone's mind that pain was just massively undertreated, just massively undertreated. I mean, it was unbelievable in the 1970s how we blamed people for their pain. We made jokes about it in the hospital. I mean, it was just massively undertreated, and that got a little better in the 80s, not much. Hospice came along, growing perception, and then in the 90s it finally hit. It's like progress in anything. It starts out and then it sort of goes like this. In the 90s it really hit, and pain became the 5th vital sign. Every time a nurse asks you, "How's your pain today?" So they're like, "Oh, let me check. How are you?" And so we went from being massively undertreating pain to a lot of problems with narcotics. I don't want to say overtreating pain because we still undertreat pain sometimes. And pain is like, if you think about what it is to be a physician, that's our primary responsibility, to relieve suffering. It's not to do catheterizations, it's to relieve suffering. And so, we have to be attuned to try to relieve the pain in our patients. But what's happened in the 2000s is there's been a lot of diversion of these drugs. There's been a lot of pain clinics. There's been a lot of deaths. There was a very nice article in the New Yorker maybe 3 months ago that did a very sympathetic portrayal of the confusion that medicine is now facing with these issues. It's not like, oh, I understand, here's the way. I don't understand. I mean, I know that we undertreated pain. I know that's bad. I know now that there's a lot of abuse of these drugs. I know that's bad. And so the point behind this proposal then was we need more data. It's going to be complex any way you look at it. It's not going to be clean, but we just need more data. And so we decided to exclude the people with cancer and just look for non-cancer pain. One of the things that I would not have predicted is that 35% of all beneficiaries got a prescription during a year. 35%. I told my nurse practitioner, and you're responsible for half of them.
It's 10%.
Huh?
200,000 is 10%.
No, but it's 35% of this is the denominator. That's the denominator. That's the first place we asked the question, did they get a script?
Yeah.
And this is a cumulative distribution, whatever the opposite of cumulative is, a receding distribution of how many days supply they got versus percent of the people. So of this 35% of people who got one, about more than half got a 30-day supply. And then 27% got at least a 90-day supply. And that's not, you can't give a 90-day script. That means that they got 3 scripts. And then 17% got over 180, which we consider to be basically probably full-time then. So that's just, once again, description. Here are the types of drugs. The ones on the top are the ones that we give out like candy. These are the heavy hitters that certainly are used in cancer all the time and are used in hospital medicine all the time. And then there are, but none of these are, by the way, hospital or hospice or nursing home. These are all outpatients. And so these are the ones that are, once again, a little surprising that the prevalence is so high.
The breakdown of the top category, the oxycodone, I'd just be interested over time, the changes, because those drugs tended to, I think, I would imagine, based on experience, that there would be a drop in codeine and a rise in oxycodone.
Yeah, good point. We have it. I'm not sure we've printed it out specifically. I looked at time trends of each of those three. And by the way, all the analyses I'm going to tell you now are under revision. So this is sort of an artist's impression of our findings, as opposed to the first data was real, that 35%. And these data are real. These are sort of bivariate analyses of factors associated with whether you got a script for an opioid. And the only thing I want to point out here, because there was something in JAMA the other day that said, said surprisingly African Americans were less likely to get it, or or it goes down with age, or things like that. And that's the trouble when the first thing you look at is the product of a multivariable analysis. Physicians do not think multivariably. We think one fact at a time. For that matter, that's the way we should think. And that's how public health thinks too. It doesn't think, it thinks how do things change with age. It doesn't say how things change with age after controlling for this and this and that. Sociologists think multivariably, and to a certain extent their thinking has a little over-influenced the way we present medical results, where we really should be paying more attention to the bivariate results than the multivariable. And this is an example, because look at the prevalence of these drugs. You look at this and what would you say? Say it goes up a little with age, right? It goes up a little with age. It goes from 34% up to 36%, a little increase. What do you say here? You say it goes down, okay? It goes down once you control for a blah, blah, blah. Here, what do you say? Say blacks are a little more likely to get it than whites, okay? 39 versus 35. What do you say here? You say whites are more likely to get it than black. So it's just, the answer gets flipped when you do a multivariable, and there are reasons to do multivariable, but the thing is that what I find in medical presentations is it's automatic sometimes, where people don't think about what question they're asking, and they immediately go and they start throwing in controls. So these are the artist's impression data. This is showing that yes, you can get variation at the level of PCP. So this is once again that same type of thing where we looked at all, except here we're looking at all the prescribers in Texas, and we're looking at the percent of each of the patients they see who got an opioid. And so some prescribers, none of their patients that they prescribed for got an opioid, and some prescribers, more than half of the patients they prescribed for got an opioid. One of the challenges and why we're having to redo this all the time is people see lots of different docs, and since we don't have we can't link it to Part A, we can't link it to Part B, we haven't assigned them a doc and stuff like that. And so in some of these multi-level analyses, actually the patient can show up being assigned to several different prescribers, which tends to screw up a multi-level analysis. So we're redoing them after assigning. But anyway, lots of variation. This just shows that 15% are significantly higher, 15% are significantly lower in PCPs, 15% that are significantly higher are responsible for 25% of the scripts. Then we looked at it we focused in on specialists, like a generalist physician, general internal medicine, family medicine, or an orthopod, or a ER doc, an emergency room doc, and looked at variation there, because these physicians should be seeing similar patients. Once again, lots of variation. You know, a lot of your chance of whether you're going to get an opioid depends on which physician you see, is what this is telling us. A little less variation for emergency room docs. This is the ICC. These are definitely artist impressions. Do not try to memorize these data, because these may change dramatically. But currently, what we're finding is that among generalist physicians, the ICC is substantial, 23%. When you see your primary care physician, 23% of whether you get an opioid rests at the primary care physician, whereas these other specialties, there's less variation. And then when we look at, once again, the 15%, or down here, the 15% of generalist physicians who are significantly higher prescribers, they're responsible for 42% of all the opioid scripts. So a small percent of providers are responsible for a big chunk of the scripts. Now that's not good, it's not bad, okay? It's just there, you know, because once again, prescribing opioids is a very complex issue. Perhaps, you know, what we haven't looked at the serious drugs. I wrote an email about that today. We ought to split out the serious, the fentanyl and all those things. But here's looking at variation, a little more relevant, you know, people who got at least 90 days of opioids with the generalist physicians. Or here's, you know, people who are chronically on opioids. Once again, fair amount of variation among the primary care physicians. So we're sort of still plodding away on that. The talk is over. Any suggestions you have now or later about, you know, how to split it off? I think that Youngfang and Mukaila did an excellent job splitting out opioids and making that like, oh, we can go get money to do that. But some of these other things, like where to go after money and stuff like that. I mean, not that that's what I'm interested in, of course. I'm interested in scholarship. But anyway, thank you. Are there questions? Comments?
These patients, there's no way to link back why they got the prescription. What type of disease do they have?
For the studies we're currently doing, there's no way. For the studies that we're proposing, I guess we could ask permission now. I mean, since we're not funded to do it, I was going to wait until we were funded to do it. But for the studies we're proposing, we can ask them to make the link to the Part A and B data so that we can link the provider, the prescriber ID. Everything is linked, the patients are linked, but the prescriber is not. And then once we link the prescriber to the providers in the Part B data, we can infer, but still it's only an inferring, right? We can say, well, we know who did it. Did that patient see that person? What were the diagnoses? But there's no diagnosis on the claim for the drug, but we could infer, and when you start inferring using Medicare data, you lose 20% of your, you know, I mean, like often, you know, you lose 20% right off the bat. There's no information on it because, you know, they call you and you tell the nurse to call in a script for something, right? And there's nothing else there.